السلايد واضح دكتور؟
جدا.
طيب، بسم الله الرحمن الرحيم. My name is Ala Al-Sabi' from Servier Company. On behalf of Servier Company, I would like to thank you for joining our webinar for tonight, the colorectal cancer webinar. This webinar will focus on the new management approaches for metastatic colorectal cancer. It's our pleasure that the speaker of tonight is Professor Ahmed Badib, Professor of Internal Medicine and Medical Oncology. He's the Chief of Medical Oncology, King Khalid Hospital, Najran. Professor Ahmed had published many papers in the field of medicine and oncology, and he has a special interest in medical education and the quality in the healthcare. Our agenda for today will start with Professor Ahmed, the presentation of new management approaches for metastatic colorectal cancer. The second presentation, management of mCRC beyond the second line. For better quality and good organization, please mute your microphone. And at the end of the presentation, please use your hand if you want to ask the question, or you can put your question in the comment box. Thank you for your attendance. Professor Ahmed, the floor is yours.
Thank you, Mr. Ala. Thank you, Ahmed. Thank you for all that, for Servier and all the attendees. I will share my slides.
Please.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وآله وصحبه أجمعين. My talk today will concentrate about new management approach for metastatic colorectal cancer. The agenda of my talk will cover the metastatic colorectal cancer size of the problem, the treatment choice in metastatic colorectal cancer concentrating upon the role of the biomarkers, the overall survival in the clinical trials, and then we'll touch the first line options. We'll talk about the treatment goals beyond the second line, concentrating upon the recourse study, and we'll conclude with the ESMO and NCCN treatment algorithm for metastatic colorectal cancer. As we know, the colorectal cancer, as based on the Saudi Cancer Registry 2015, it comes among the top 10 in the second position, taking about 12.2% of the second position of the top 10 cancers among Saudi population. If we consider the gender issue, we can see that in the top 10 cancers among men and women, we can see that the colorectal cancer comes in the first position, constituting about 15% almost of the cancers in the men, while in the females or among women, it comes in the third position after breast and thyroid with percentage of 10%. Still we are facing almost a third of the cases coming with distant metastasis, that means stage 4 colorectal cancer, with around 40% of the cases they have regional disease, while for the localized we have almost 26% of the cases. We can see clearly that the colorectal cancer is aging related. That means if we talk about the incidence, we can see that the incidence clearly correlated to the age, increasing by the age, and the same tendency of the mortality related to the increasing by the age, the same. So what about the trend and the death rates and mortality rates among colorectal cancer with favor of all these new revolution in the medication? We can see clearly that colorectal cancer is dropping in comparison with the other cancers like prostate, like pancreas, that is increasing, and prostate also. We have great achievement in colorectal cancer, and there is drop, and we are aiming for more and more achievement in this regard. So the treatment choice in metastatic colorectal cancer depend now on biomarkers. So we'll concentrate on the biomarkers. And all of us, we know that colon cancer is not one disease anymore. And many factors influencing the treatment choice in metastatic colorectal cancer. The main corners, the patient characteristic, we can see that the age, the comorbidities, the performance status, and the prior adjuvant treatment playing important role. When it comes to the tumor characteristic, we can see that the resectability of if the tumor is potentially resectable, we have to take in consideration the tumor burden and the number of metastases, the tumor location, and the issue of sidedness, as we know. Then it comes the patient preference. We have to hear from the patient and listen to his preference. What quality of life he's looking for, the toxicity profile, and then the biomarkers, which is molecular characteristic coming. And we know that now metastatic colorectal cancer, it has two major divisions, KRAS wild type and KRAS mutation. And among these, we have also sub divisions based on the presence or absence of some mutations like HER2-neu, which in the wild type found in around 3.5, ntrk less than 1%. We have the same thing for the wild, for the mutated type. We have the ntrk, we have the HER2-neu, and we have 5% of the cases they have microsatellite instability. And those patients, they have now new actionable treatment. Now, BRAF mutations, BRAF V600E constitute about 9% of the cases, which also we have many things to do for those patients. What about the sidedness? Sidedness now is very important and crucial in management of metastatic colorectal cancer. We can see that there is different story between the right side of the colon and the left side. And we have this based on the presence of multiple mutations found on the right side, differ from the left side. And we can see that we have more BRAF mutation and less wild type cases on the right side. We have also the BRAF V600E. We have also the possibility of microsatellite instability in this group of patients. Based on that, we have now the TRIBE protocol, BIF triplet chemotherapy. We have encorafenib cetuximab beacon protocol, and we have anti-PD-L1 and Keynote 177 protocol. While in the left side, we have more targetable mutations because we have this wild type nature more prevalent in this side. And based on that, you are using anti-EGFR. We have more chance also of HER2-neu positivity. We can use anti-HER2-neu therapy. And for all these cases, remaining bifacizumab plus chemotherapy available option for all these group patients. So now we have the luxury of so many options. How do we can personalize the therapy? We have now for every patient, we have to design special treatment protocol. We can use TRIBE approach by using FOLFIRI versus using 5-FU, FOLFOX or FOLFIRI. We can use the crystal approach by integrating the cetuximab to the FOLFIRI protocol. We can use also cabecitabine-based protocol, KBOX, with the approach of 1016966 trial. What we achieved in terms of overall survival through the clinical trials, we can see that we have proportional impact on the magnitude of overall survival benefit achieved across lines of therapy. We can see that we have, despite of crossing all 3 lines of chemotherapy, and progression of the disease, still we are gaining in each line of therapy overall survival benefit. And we are still preserving a good hazard ratio despite of the disease progression and the stage of the disease. If we see here that in the first line, we are achieving around from 4.2 to 1.4, depending on the protocol and among these first line cases. When we go to the second line, in which we are using FOLFOX or FOLFIRI as backbone, then with either BIF or panitumumab or ramucirumab or aflibercept, in these cases we are achieving a range of 2.1 to 1.4 overall median overall survival. When it comes to the third and fourth line, we have the regorafenib and TAS-102 with very impressive hazard ratio. We can see here in TAS 0.68 hazard ratio. We are talking about third and fourth line. Despite of that, we are still achieving a lot in this advanced stage. This is the hazard ratio across the lines of treatment. So from this hazard ratio, we can say simply that patients should be exposed to all active and approved agents during treatment. We can see that we reached up to 26.4 months by the using of the third line. And this is meta-analysis long time ago, just by the introduction of the new drugs like Oxal and irinotecan with the targeted therapy. We can see this is 1992 that there is clear separation of the curve. We achieved a lot, and this included, or after the inclusion of the CLGB SWAG trial, we will compare simply the 5FU to these new drugs. We achieved huge separation of the curve and improved survival. So classically, when we calculate the survival, we can see that we are achieving now almost 32 or more months in the metastatic colorectal cancer by the favor of the multiple lines of treatment. So we can achieve 5 months by the first line induction. We can add 6 months by the maintenance after the first line. Or then we can add 3 months if we use the reintroduction for the first line. And then when we added the second line, 4 months at least we can achieve. When we start using stop and go strategy, 3 months with the 3 months break, we can get these 3 months in addition. For the third line, we can achieve 3 months also. For the salvage and fourth line, salvage third line, we can also achieve 3 more months. And the pre-terminal stage will complete the 32 months. So what options we have in the first line? And how can we optimize the first line treatment option? Based on that, we have to divide the patient on wild versus mutated. So we'll talk first about wild type RAS metastatic colorectal cancer. And we have landmark trials comparing the use of anti-EGFR for we are talking now about the wild type. We have the FIRE3 and CLGB SWAG, which compared the anti-EGFR versus the FIGIF. We can see, we'll see the result now. This is these two trials are phase 3 trials, FIRE3, CLGB SWAG. And we have for panitumumab, the PEAK trial, which is phase 2 trial, and it is comparing the panitumumab versus PIF. What was the result? This is very impressive forest plot showing that the anti-EGFR win. We have clear tendency and success for the use of the in favor of anti-EGFR in the first line for the patient on the either FIRE3 or PEAK or CLGB SWAG, either using cetuximab and FIRE3 and CLGB SWAG, or using panitumumab in the PEAK trial. And clearly we can see that there is clear benefit in the overall survival in favor of this of the using of anti-EGFR versus the use of the VEGF in the first line in wild type metastatic colorectal cancer. What about the sidedness? For the sidedness, we can see clearly that, as we mentioned before, we have different mutations and we have different targets. So this sidedness, it has prognostic and predictive value. We can see clearly that overall survival, as seen in CLGB SWAG trial, by using of anti-EGFR, clearly the left-sided colorectal cancer, they gained better overall survival. So we have good prognostic value for the sidedness. And when we separate the types in each side, we can see clearly the red color, which is the use of anti-EGFR on the left side, when that indicate we have clear predictive value for the use of the anti-EGFR in the first line. And clearly we can see the separation of the curve, the difference in the separation of the curve between BIF and cetuximab. We can see clearly wider curve and wider separation, and we have clear benefit by using the anti-EGFR on the left side in comparison with the right. The right, they achieve it only 16 months, while for the left we achieve it 36 months overall survival, and clear benefit, much higher benefit for the cetuximab and anti-EGFR over the bevacizumab on the left side also. We'll conclude from these data that for any patient with left-sided metastatic colorectal cancer, we have to check the KRAS mutation, and if he is wild type, of course, we have to use anti-EGFR. If mutated, we have to use the anti-VEGF in addition to the backbone doublet. If the patient right-sided, we have to assess the factors which we mentioned, and we have to decide to use doublet or triplet with anti-VEGF, and there is no place for the EGFR. What about MSI high metastatic colorectal cancer? The landmark trial released on ASCO, this virtual ASCO 2020, will give the answer. This trial tried to compare the pembrolizumab versus investigator choice in the first line for patient with MSI high, treatment naive, performance 0 to 1 with measurable disease, and the endpoint were the progression-free survival, overall survival, and many other secondary endpoints, and the tumor response assessed by RECIST criteria by central review. We can see very impressive result and success for the use of pembrolizumab versus the investigator choice. We can see at 24 months, almost 48% of the patient disease-free, while only 19% of the chemotherapy patient, with very impressive hazard ratio 0.6 and p-value 0.0002. As usual, we can see that the onset of response for patient used chemotherapy, initially they achieve quicker response, but then we can see the great separation of the curve with the durable response almost near plateau. What about the response? The response clearly and impressive response, we can see that 43% overall response rate in the pembrolizumab versus 33% in the chemotherapy, with the complete response in around 11% of the cases in the Pembro, in comparison with 3.9 in chemotherapy. And still, we did not achieve our goals and much and higher response. We are aiming for better protocols, better manipulation of the immune therapy to achieve better response, because still we have stable disease higher in the chemotherapy arm, and we may see disease control rate a little bit higher in the chemotherapy. That means we did not achieve our final goals, and in this regard. What about the median time to response? Or again, this is the same issue we are facing with immune therapy, that there is some sort of delay in the initial response. We can see that chemotherapy a little bit quicker, showed quicker response after initiation. But the depth of the response, radiologically in the target lesions, we can see very deep response clearly seen in the pembrolizumab versus chemotherapy. So deep response clearly visible here. The duration of response, as we mentioned, we have at 2 years, 80% of the patient are disease-free, in comparison with only 35% for those patients using chemotherapy. When it comes to the immune-mediated side effect, we are expecting, of course, that will face a little bit higher immune side effect in the Pembro in comparison with chemotherapy. This is the immune-related, but most of them are grade 0 and 1, while for grade 3 and more, it is only 9% of the cases. And death 0, we cannot see any death cases in both arms. And so the conclusion of the Keynote 177, we can say that pembrolizumab provided clinically meaningful and statistically significant improvement in progression-free survival versus chemo, and the median progression-free survival, it was 16.5 versus 8.2, with significant hazard ratio and p-value almost 0.002, as we mentioned. And we have 24 months progression-free survival, 48%, and the response was durable, and the duration of response not reached in the pembrolizumab versus 10 months in the chemotherapy. And the safety profile in general, we're talking about treatment-related events, we can see that only 22% found in Pembro in comparison with 66% events in the chemotherapy. So the pembrolizumab should be new standard of care as first line in patient with microsatellite instability. So we added to our treatment protocol now the use of Pembro or immune therapy in MSI high. We can use either pembrolizumab or Nivo-EP in this regard. What about the BRAF mutant metastatic colorectal cancer? We have historical data from TRIBE trial, the phase 3 trial, which compared the triplet fulfoxiri versus the fulfiri-bif. So they compared fulfiri as doublet fulfiri-bif versus fulfiri-bif in the first line setting. And we can see that the triplet therapy fulfoxiri win with the increase in the overall survival, reaching 29.8 in the fulfoxiri plus bevacizumab, in comparison with 26 months in the patient received only fulfiri bevacizumab, the doublet. And when we see the subgroup analysis, the first plot, we can see that the most beneficial people, that those with right colon and the patient with BRAF mutated status, and those are the higher risk group. Those are the most beneficial group who benefit from the triplet approach. When we came to the side effect, as we expect, usually the neutropenia is the main side effect. It was 50% 36% in the triplet versus 20% in the doublet, with the peripheral neuropathy is the second side effect, which is 13% in the patient received triplet therapy with 0 on the doublet arm. So can we do more for BRAF mutant? We know that the BRAF resistant mainly coming from the MAC pathway. MAC pathway composed of BRAS and BRAF and MYC, and also we have the ERK, which is extracellular signal kinase. So for BRAF, we can use now, we have many options, femurafenib, encorafenib, and dabrafenib. For MYC, we can use cobimetinib, tramitinib, binimetinib. So what we have to do, we have to target all, we'll try to combine many drugs to stop or to attack the resistance to BRAF V600E, in addition to the use of the EGFR also drugs, anti-EGFR drugs. We know that the inhibition of BRAF usually leads to feedback reactivation of the EGFR signals. So the idea of combination now is a standard as per the clinical data. Based on that, many trials trying to tackle the issue of BRAF V600E, that we know that the prevalence of that mutation is around 8%. We can see that many trials using femurafenib with or without cetuximab, dabrafenib with tramitinib, or dabrafenib with panitumumab, and also the triplet, but we did not achieve what we expected as we saw in melanoma. Still, the range of response disappointing, and the highest achievement was with the use of the triplet, ranging from 23 to 32% response rate. Till the Beacon protocol came, trying to testing and evaluating the triple therapy in BRAF mutated colorectal cancer. This is the design of the trial, and we saw the updates of the trial in the virtual 2020 ASCO. They tried to compare the triplet using encorafenib, binimetinib, cetuximab versus the doublet encoracituximab. And we know that binimetinib is the MYC inhibitor, and in comparison with the standard treatment for cetuximab as the third arm, we can see that both the triplet and the doublet, they achieved great overall survival, almost double for the control. We can see that we have a little bit better separation of the curve using the triplet, and we have better also hazard ratio using the triplet. It is 0.52 in the triplet, while 0.6 in the doublet. And when we talk about the response rate, we can see that the triplet achieved around 26%, while using the doublet, we achieved around 20%, and for the control only, we achieved only 2%. So what about the depth of the response? Again, we can see that the triplet showed more deeper response in the target lesions. So if we compare it with the doublet, and if we compare it to the control group, of course. But it's still comparable with the doublet and triplet. There's a mild difference in the depth, but it is comparable both together. Now, we achieved it almost lower reduction in the death, around 48% lower reduction in the death, the triple therapy, 40% in the doublet, in comparison with, and it is almost the survival 9 months in the triplet, 8.4 in the doublet, 5.4 in the control group. Quality of life maintained. There is no overall difference in the triplet versus doublet. Then the update came in virtual ASCO, this meeting 2020, that showed that we don't have much difference. There is overlap between the survival benefit for the triplet versus the doublet on comparison with the control. Based on this data, which did not show marked superiority of the triplet over the doublet, the FDA approved the doublet therapy as for the treatment. That means encorafenib in combination with cetuximab in patient previously treated BRAF mutation, and should they consider it and suggest it to be standard of care. We can say that encorafenib and cetuximab with or without bini is superior to the, of course, the classical or the standard of care. And the two-drug combination of Encora with cetuximab has equivalent survival, and is the doublet is better tolerated than the triplet combination. We have now promising trial at phase 2 regarding the use of this triplet therapy in the first line, which Anchor CRC, again, this one presented at ASCO 2020, and they are asking why not to put the triplet therapy in the first line instead of the third line as done in Beacon protocol. And again, we achieved excellent response in the first line for the triplet therapy, with response rate almost 50% and disease control rate reaching up to 85%. So based on that, now we introduced the treatment of anti-BRAF for patients with the mutated BRAF that we can use in the first line triplet therapy with anti-VEGF, and in the second line we can use the doublet protocol, what's called Beacon approach. What about HER2-neu amplified metastatic colorectal cancer? We know that we have classically we have a prevalence of 2% of the HER2-neu. Now, if we choose our patient with high probability of HER2-neu positivity, mainly those with wild-type RAS and BRAF, those with resistance to anti-EGFR therapy, those with left colonic cancer, we can increase the chance or the prevalence to up to 5 to 8%. And here we can see the effect of the amplification of the HER2-neu. We can see that the response to the anti-EGFR in terms of progression-free survival is much less in those patients with HER2-neu amplification. It drops from 8.1 in those with HER2-neu negative to 2.9 progression-free survival. So for that, Heracles trial tried to use trastuzumab plus lapatinib to deal with those patients who histologically diagnosed as metastatic colorectal cancer, HER2-neu positive, KRAS wild type with prior treatment with the 5-FU irinotecan oxal, and they treat the patient under disease progression or intolerability. What Heracles showed by the use of trastuzumab and lapatinib, we achieved response rate of almost 30%. 4 patients achieved complete response, and 30% achieved stable disease with disease control rate of 60%. Can we replace the lapatinib by bertuzumab? They tried that in my pathway trial and achieved similar almost to the Heracles. We achieved response rate of 32%, disease control rate of 44%. What if we tried using anti-TDM1? We can see this is a case report trying to assess the response to the TDM1 in this situation, and this will open the way for another clinical trial. We can see clearly the response rate in the liver metastasis or colorectal cancer in this CT scan. What about using the new generations of the trastuzumab? That means trastuzumab DXd. We can see in the answer comes from again ASCO 2020 virtual meeting. We can see clearly that the response here by Destiny trial, Destiny CRC, and we achieved response rate of, for those with HER2/neu, 45%, and we achieved the mostly partial response and stable disease. And the duration of the response, this is the most important issue that not reached that mean till now. And clearly we can see the depth of the response and the best change in the tumor size by using of the new generation trastuzumab. What about the use of ntrk mutant? What about the dealing with ntrk mutant metastatic colorectal cancer? We know that colorectal cancer almost comes in this position here among the other cancers that showed response to larotrectinib, which is the attacking or dealing with the ntrk fusion. We can see that, but we know that the ntrk fusion is almost less than 1% in colorectal cancer, but it showed again very excellent response, reaching up to 65%. So how to optimize the first line? We will summarize. We have to consider the tumor burden. If we are looking for if it is resectable or not, we are looking for downstaging, potentially resectable or unresectable. So we have to use the protocol based on our aim. And then we have to see the patient performance status, fit or not fit. And then we have to consider the biomarkers. So we have to do at least the RAS and BRAF and MSI in the front line, because now we have the Keynote 177 and we have the this beacon protocol approach, and we can anchor approach for the BRAF that we can try, and also the previous tribe protocol. And for the later lines, we have to do the HER2/neu, ntrk, ROS, and ALK should be tested. And then we have to consider very important factor, which is the sidedness. So what about the second line? What are the treatment goals in the second line? Our goals, usually we are aiming to extend the survival with durable disease control and to preserve the performance status. We'll give concentration mainly on the recourse study, and this recourse study is multi-center randomized double-blind placebo-controlled phase 3, stratified the patient based on the KRAS status, time from diagnosis of metastatic disease, geographical region, and the treatment continued till disease progression or interbal toxicity or patient refusal. It included almost 13 countries and 116 locations. They included patients with metastatic colorectal who previously received 2 or more lines, and they were refractory or intolerable to 5-FU, irinotecan, Oxal, BIF, anti-EGFR. And we have to know the KRAS status, and the patient should be with good performance status 0 to 1 and age more than 20, adequate bone marrow, liver, and renal function. And so they recruited almost 800 patients with primary endpoint overall survival, secondary progression-free survival, response rate, and rate of disease control and safety. So they compared TAS 102 with best supportive care versus placebo. The demographic feature and disease character of the patient were well balanced between the 2 study arms. We can see they are included even till the age of 82, and they recruited different races from different geographical regions with performance, as we mentioned, 0 to 1, colon and rectum, and they recruited both KRAS mutated or wild, and they stratify the patient based on the time between diagnosis of MITS till time of randomization, because for prognostic purpose. And they recruited patient with 2 lines, two prior lines or previous lines, 3 lines, 4 or more, and all the patients, they used multiple lines of treatment, and most of them, they were refractory for fluoropyrimidine. What was the results? We achieved it almost at 1 year. 27 patients who received a TAS, they were alive at 1 year in comparison with 16.6 only in the placebo. Hazard ratio very impressive, 0.69, with reduction in the that mean reduction in the risk of the death with TAS almost 31%. This is the primary endpoint. What about the progression-free survival? We can see that 47% of the patients treated with TAS, they were progression-free at 2 months time, in comparison with only 20% with placebo, and with very nice hazard ratio 0.4. This means that we are reducing 50% the risk of death, the risk of progression by the use of TAS. In addition to that, we are maintaining the performance status 0 to 1. We are maintaining it almost 5.7 months in the TAS arm in comparison with the 4. That means TAS did not affect negatively, the opposite. It maintained the performance status, and almost 34% of the patient who used TAS, they maintain the progression, they maintain the good performance as 0 to 1. And this figure can simplify the issue. We can see the baseline performance status of the patient did not change much at the time of discontinuation. What this mean? Almost 84% of the patient used TAS, they kept or maintained good performance status 0 to 1 at the time of treatment discontinuation. So the treatment did not affect negatively their performance status. We have some updates, very nice updates, that gave us some prognostic characteristic to those patients who might benefit more from the TAS. This is exploratory post hoc analysis. We can see that we can divide the patient based on the number of MITs, 1 or 2 versus 3 or more. If it is 1 or 2, we consider good prognosis, and less than more than 3 or more, this is bad prognosis. The other factor, which is the time since the diagnosis of the first MITs, if it is more than 18 months, that means long time between the previous line and reaching to the TAS arm. This means the patient has good prognosis, and we'll see now this effect on the overall survival and progression-free survival. And better than all these, if the patient has no liver mets. If no liver mets, that those are what we call them best prognostic group, best prognostic characteristic. So what this means in terms of overall survival, we can see the best group who have no liver mets and 1 to 2 sites only, with the longer duration of more than 18 months from the time of diagnosis of MITS, they achieved very nice duration of median overall survival, reaching up to 16.4. For the good prognostic, those with that may include liver mets, they achieved 9.3. While those with multiple sites and shorter duration of response to the previous line, they achieved only 5.3. Still, despite of that, we have a good hazard ratio for the intention to treat, for the good prognostic and the best prognosis and the poor. The same reflected on the progression-free survival. We can see the best group without liver mets, they have the best response, while those with good prognostic features but they have liver mets, they achieve a 3.3, while those with poor prognosis and multiple sites and shorter duration of response almost achieved only 1.9 months. This also, the prognostic scoring also reflected on the preservation of the performance status. We can see clearly that almost 90% they maintained 0.1 progression performance status, while those with poor performance only 78%. What about the safety profile? We can see that it is comparable. If we compare between placebo and the test, we can see that toxicity or the side effects, mainly the grade 3 and 4, comparable to placebo. What this means for us, that most of these side effects are disease related rather than treatment related, and we don't have any serious major serious side effect. And we have the main toxicities are nausea, vomiting, decreased appetite, fatigue, diarrhea, abdominal pain, fever, and asthenia, which almost all of them, they are grade 1 or 2, while for grade 3 not more than 2%, and those comparable to the placebo. This means that they are disease related mainly. When we come to the fluoropyrimidine related toxicity, as we know that we have usual neutropenia and febrile neutropenia, but it is very low. It is 4% of the cases, and we have only, we don't have that stomatitis which we see in patients with 5FU. We don't have hand-foot syndrome that we see in the 5FU, and we don't have the cardiac ischemia or cardiac tox. It is less than 1% in the TAS group. When we talk about the laboratory abnormalities, the main issue is neutropenia related, which is we can see in 38% of the patient. But the febrile neutropenia, it is only 4%. Others are all negligible side effects. That means we have neutropenia, leukopenia, anemia, while the others are negligible. So the good news about the neutropenia, which came from subgroup analysis, we can see that the neutropenia severity during the first treatment cycle of TAS associated with better efficacy and survival. They divide the grades of neutropenia to A, B, C, D. Those with grade 3 to 4, they call it category D, and those patients, they have significantly longer progression-free survival. So we'll conclude our talk by just mentioning the ESMO guidelines regarding the algorithm treatment. We can see that, as we know, that for RAS wild type, we have to use, we have to consider the sidedness, and we have to choose either EGF, the chemotherapy plus minus EGFR or bevacizumab, depending on the side. And if we failed the doublet, we'll go to the second doublet, switching the treatment the chemotherapy backbone. If the patient progressed on the second line, then we have to go to either regorafenib or TAS. If the patient did not expose it before to EGFR and he's wild type, we have to give him the chance using anti-EGFR. For the fourth line, the only available options is Rigora or this TAS. Now, for the wild type, we have to assess the factors which you mentioned before, either to use the doublet or triplet. Then we have to switch the backbone, and then we'll go for the third line in regorafenib or TAS. And the fourth line, we have the possibilities either to use Rechallenge or to use Rigora or TAS. The NCCN guidelines almost running in the same direction based on the previous backbone used. If we used Oxal, then we'll use FOLFIRI-based protocol, either to use FOLFIRI alone or FOLFIRI with BIF, which is the preferred, or we can use FOLFIRI with aflibercept or ramucirumab. We can use irinotecan BIF. If the patient has some sort of mutation, the BRAF, of course, we have to use the beacon protocol. We can use also if the patient has, of course, we can use tribe protocol. We can use beacon protocol. We can consider the use of keynote protocol if we have the MSI high patient. If the patient progresses on these lines, then we have to use the subsequent, depend, as we mentioned before in the ESMO guidelines, based on what the patient received in the second line, we can choose one of the third line options that we have. And the only thing remaining for the fourth line is the regorafenib and TAS. The same for if the patient received irinotecan-based treatment, so we have to make to the opposite. We'll give the patient FOLFOX-based protocols, and we'll run through all the same cascade. What about if the patient has received previously both FOLFOXIRI protocol, that means he used Oxal and irinotecan? So in this, we have to, in this regard, we have to use either irinotecan, cetuximab, or panitumumab, especially if the patient BRAF wild type. If the patient BRAF wild, if the patient BRAF mutated, we have to include the encorafenib. We have also the option to use regorafenib or TAS. And if the patient has MSI high, we have the option either nivolumab epi or pembrolizumab. And if HER2 new, of course, we can use the anti-HER therapy. And subsequently, we can use rigora, TAS, no superiority of one over the other, and the other immune therapeutic or anti-HER therapy. Thank you. And this is the end of my talk.
Thank you, Dr. Ahmed, for the great presentation, very informative. For the sake of time, I will just stop sharing and will share my screen for the second presentation.
Okay.
Can you see the presentation,
yes,
Doctor?
Yes, very nice, yes.
Okay.
Okay,
so I will just talk about the management of... yes, Doctor?
Yeah, it is my pleasure now to introduce Mr. Ala Al-Sabi'. Mr. Ala, he is medical science liaison in hematology oncology of in Sofia. He's graduated as a pharmacist from Jordan University of Science and Technology in Jordan. His presentation will talk about the management of, again, the metastatic colorectal cancer from mainly pharmaceutical point of view. The web is yours, Mr. Ala.
Thank you, Doctor. Just I will not go through every details about the guidelines. Dr. Ahmed successfully explained the guidelines very nicely. Just to say that in the third line or beyond the second line, we have, according to the ESMO guidelines, two options: the regorafenib or trifluridine or TAS 1 or 2, both in wild type or RAS wild type or RAS mutant or BRAF mutant. It is effective in both cases. And also in the NCCN and the latest guidelines, you can see that TAS or trifluridine is recommended in third line. So I will just focus on what is trifluridine or what is TAS 1 or 2. The indication approved by the FDA, the EMEA, and the Saudi FDA is trifluridine is indicated as monotherapy for the treatment of adult patients with MCRC who have been previously treated or are not considered candidate for available therapies, including fluoropyrimidine, oxaliplatin, or irinotecan-based chemotherapy, or anti-VEGF or anti-EGFR agents. So this is the indication from FDA, EMEA, and even the Saudi FDA approval. The mechanism of action, it is a simple medication. It's a combination of trifluridine and tipiracil. Trifluridine is a thymidine-based nucleoside, which is incorporated in the DNA in the tumor cell following phosphorylation. Tipiracil is a thymidine phosphorylase inhibitor, prevent degradation of trifluridine. So simply, trifluridine, once enters the body, it may enter cell by active transport by the nucleoside transporter, or it can go by thymidine phosphorylase inhibition. So it will degrade trifluridine. That's why tipiracil is available in combination with the trifluridine. It will inhibit thymidine phosphorylase, so it will enhance the bioavailability of trifluridine. So it will go and have its action on the cancer cell. Once upon entering the cell, trifluridine is phosphorylated by thymidine kinase, triple phosphorylation. This triple phosphorylated form of trifluridine will be incorporated in the DNA, resulting in abnormal DNA synthesis and inhibition of the cell division. So simply, trifluridine tipiracil go in the DNA dysfunction through DNA incorporation. It will lead to preventing of cell proliferation, and this will lead to anti-tumor activity. Trifluridine tipiracil or TAS102, it is a fluoropyrimidine-based medication, but it differs from 5-FU because trifluridine tipiracil or TAS102, it inhibit DNA through DNA incorporation, so it will lead to DNA dysfunction, but 5-fluorouracil inhibits thymidine synthase, which lead to DNA synthesis inhibition. So what is the difference between TAS or 5-FU? It is demonstrate TAS or trifluridine tipiracil demonstrate significant efficacy both in 5-FU sensitive cells or 5-FU resistant cell NCRC. So it is very effective in patients that have 5-FU sensitive xenograft or patient resistant to 5-FU. What is the dosing and the treatment cycle? 5-FU or trifluridine tipiracil or TAS1 or 2, starting dose will be 35 per milligram per meter square per dose. It is a twice daily medication. It's an oral medication, twice daily. And the adjustment is according to the patient's safety and tolerability. So we have two forms of TAS102, 15 milligram tablet and 20 milligram tablet. You can see here from the paragraph that the TAS102 depend on the BSA of the patient. The dose will be fixed for him for twice daily medication. Like, for example, if the patient have BSA is less than 1.07, he need 35 milligram twice daily. So 35 is 15 plus 20 milligrams. So one tablet of 15, one tablet of 20. If the patient like need the dose of 60, he needs 3 tablets of 20. If the patient need like 75, the addition of 1 tablet of 15 and 3 tablets of 20 will give him the 75. So both medications should be available in the pharmacy when the patient will need it. The dose should not exceed 80 milligram per dose. This is the maximum dose for TAS102 for the patient. The tablet must be taken with a glass of water within 1 hour of completing the morning and the evening meal. So it should be taken with meal within 1 hour in the morning and in the evening. One note here that TAS102, 15 milligram and 20 milligram, both are available in NABCO. So you can order it from NABCO. The cycle is 28 cycle. It is very simple. The patient will take TAS102 or trifluridine tipiracil in day 1 to day 5 in the first week. Then there will be 2 days of pause. Then he will take the medication from day 8 to day 12. Then 2 days pause and pausing for 2 weeks. So this is the cycle. He will take it, or the patient will take it twice daily in the morning and the evening with the meal. Okay. So simply 1 to 5, 8 to 12, then pausing for the next cycle will start after 28 days. Before starting, you should obtain a complete blood count for the patient, evaluate renal and hepatic function, and monitor protein neurobiodipstic and urinalysis. Treatment should not be used if the patient have absolute neutrophil count less than 1.5, platelet count less than 75, of the patient have unresolved grade 3 or 4 non-hematological clinical relevant toxicity from prior therapy. The patient has hereditary problems for lactose intolerance or lactose deficiency. During the treatment, the patient should obtain a complete blood count to monitor the toxicity, careful monitor for the bone marrow suppression and infection. If indicated, appropriate measures such as antimicrobial agent and granulocyte colony stimulating factor should be administered. Carefully monitoring for the nausea, vomiting, diarrhea, the GI toxicity. Patient with moderate to renal impairment should be monitored for the frequency of hematological toxicity and monitoring proteinuria. What about the safety profile? As Dr. Ahmed mentioned in the CURICORS trial, that the toxicity are two types, GI toxicities and hematological toxicity. The GI toxicity, as you can see, is very minimal. It is almost comparing with the placebo arm. The grade 3 to 4 is very minimal, less than 4% of most of the GI toxicity, but it is can be happen with the patient. The hematological toxicity mainly are neutropenia, leukemia, leukopenia, anemia, and thrombocytopenia, and only 4% for the febrile neutropenia. TAS-102 does not have incidence of cardiac toxicity or hand-foot syndrome like other medication. So treatment with TAS-102 or trifluridine is not associated with stomatitis or cardiotoxicity, which is associated with fluoropyrimidine. Unlike other therapy like chemotherapy and regorafenib, this does not have hand-foot syndrome side effect. Only 4% of the patient receiving TAS-102 and 2% of the placebo patient withdraw from the study because of the side effect. Dose reduction was not required in 86% of the patient using TAS-102. Total of 53% of the patient treated with TAS-102 had dose delay more than 4 days due to toxicity. How we can manage the toxicity of TAS-102? As I said, that most of the toxicity are GI and hematological toxicity. Adverse event associated with TAS-102 can be managed by delaying the start of the next treatment cycle. Dosing adjustment may be required based on the individual safety and tolerability. The maximum of 3 doses reduction are permitted if the patient needed to reduce to 20 milligram per meter square day twice daily. So if the patient need to reduce the dose, only 3 times permitted, and it is not permitted to dose escalation once the patient reduced the dose. Effective management of adverse events is essential to ensure clinical benefit of trifluridine tipiracil. So this is the scheme how to manage the toxicity. If the patient have thrombocytopenia or neutropenia, if the grade 2 to 3 for thrombocytopenia, the platelet count is more than 25 but less than 75, there is a pause or delay until the resumption criteria of more than 75 be reserved, and the reinitiation will be with the previous dose. But if the patient has thrombocytopenia of grade 4, platelet count less than 25, we will delay the use. But if the delay need less than 1 week, he will start with the previous dose. But if the delay will take more than 1 week for the next cycle, start with TAS-102, but reduce the dose by 5 milligram per meter square per dose. Neutropenia, almost the same. Grade 2 to 3, pause until resumption criteria and restart with the previous dose. Grade 4, wait till the resumption criteria. If the criteria or resumption need take 1 week or less, with the previous dose you can start. If the patient need more than 1 week to resolve to the criteria, reduce the dose when start again. Talking about febrile neutropenia, neutropenia of the neutrophil count less than 1, with a single measurement of more than 38.3 or a sustained temperature of more than 38 degrees Celsius for 1 hour, you should delay till the resumption criteria of improving the febrile neutropenia, but you should start with the reduction of the dose with the next cycle by 5 milligram per dose, per meter square per dose. Non-hematological grade 3 or 4 adverse event, except for grade 3 nausea or vomiting, delay the next cycle, and when it is resolved, start with the next cycle, but with reduction of the dose by 5 milligram per meter square per dose. What are the precaution and contraindication? GI toxicity can be should be monitored and can be treated with anti-emetic, anti-diarrhea, or fluid replacement. Hepatic impairment, there is no dose adjustment for the mild hepatic patient, but not recommended for moderate or severe hepatic impairment. Elderly, no dose adjustment needed for elderly patient. Pediatric, no relevant use with pediatric. Race, there is no dose adjustment based on the patient race. Lactose intolerance, patient with hereditary problem of galactose intolerance or lactase deficiency or glucose galactose metabolism should not take trifluidine tipiracil. Fertility, there is no data available on the effect of trifluidine on human fertility. What about renal impairment? Three category of renal impairment. If the patient have mild to moderate renal impairment, no dose adjustment is needed. If the patient have severe renal impairment with creatinine clearances from 15 to 29, the starting dose will not be 35 per meter square per dose, but it will start with 20 milligram per meter square per dose twice daily. And if the patient need to reduce the dose, or the dose reduction should be because of the adverse event, it is permitted for one dose reduction, not like three, like in the other cases, permitted three dose reduction. This is only 1 to 15, and dose escalation is not permitted after it has been reduced. After the one, if the patient still need to reduce the dose, you should stop the medication. End-stage renal disease or patient need dialysis, it is not recommended because we do not have studies on these patients. Also, it is not recommended for pregnant patient. Women with childbearing potential must use highly effective contraceptive. It's more preferable to use barrier contraceptive method. Breastfeeding should be discontinued during the treatment. And thank you for your listening.
Thank you, Mr. Ala, for the excellent comprehensive presentation. And I think now the time for questions. If we have some questions.
Yes, there is one question, Doctor, in the chat room.
Yes.
Question from Dr. Zahir. In patient with right side RAS BRAF wild type metastatic colorectal cancer, those who are initially irresectable but potentially resectable, what is your recommendation for this group of patients, considering that there was a clear overall response rate benefit with cetuximab FOLFIRI versus beva FOLFIRI in FIRE3?
Yeah, I think the answer is clear from the CLGB. CLGB showed inferior outcome for the use of EGFR on the right side. So no question about we don't use classically the EGFR on the right side. And we showed clearly the curve, how narrow the curve by using of the EGFR on the right side. And they may be detrimental as showed by the CLGB trial. So for the right side, if it is wild type, of course, we have either wild type or mutated, we have to use BIF backbone, as targeted therapy in addition to the backbone. Now, if you are looking for resectability, we may use the tribe protocol. That means we have to use that triplet rather than the doublet. And this is the most, if the patient performance status is good and the tumor burden is high and the patient has, we are planning him for resectability, that mean for down staging, the tribe protocol is the key. So we have to use FOLFIRI with the bevacizumab. If the patient, BRAF mutated, of course, we have to consider the Beacon protocol, which using now the recommended and the FDA approved and the standard is to use, we can consider, the doublet if the patient failed the first line. Still the first line till now is the fulfoxiri fulfoxiri versus the doublet, that we either doublet or triplet, while if we are going to consider later on, after the introduction of the phase 3 trial of anchor anchor trial, then this is the future for the BRAF mutated, the anchor protocol, that means using the triplet. Till the moment, what we have is trial protocol for fit patient. That means triplet therapy.
Okay, thank you, doctor. For the audience, you can unmute and ask your question. A question, doctor. Do you do tests for mismatch repair, HER2 or ntrk in your department?
In our setting, the available test by partnership with the drug companies is testing for mainly KRAS mutation. We are trying, of course, now the standard to do the KRAS. Now after Keynote 177, we have to use also the MSI testing and BRAF. But we don't do it routinely. We are now searching for sponsor to help us in this regard to do the BRAF and the MSI, while we are doing, of course, for all the patient, the KRAS. It is mandatory, as we showed in the biomarker identification, to do the three, at least the three biomarkers in the first line setting, in the early stage. I mean, as first set in the first step in the early treatment of the metastatic in the first line setting. The others are optional. If we can't do them, we'll need them, of course, later on. But the three mandatory are the three which mentioned.
Okay, doctor. Question: do you start to adopt the new data of Bacon in your current practice, and what is the percentage of BRAF mutant patient you see in the department?
As you mentioned, we are many centers in the Saudi Arabia, they don't do routinely the BRAF, so we cannot mention clear figure. But for Bacon protocol, we are facing two issues. The first of all, we have to have the BRAF testing first. The other issue that we have to have the availability of the drugs. Now, for the encorafenib is not available as formulary. We are looking for it, inshallah, to become available soon. But what we are using now is the trial protocol, the triplet therapy, rather than the Bacon. But we know that Bacon is for the second line and should be standard. And when we have this patient with BRAF mutation, failed the first line for fulfoxiri, we have to proceed and to do the BRAF testing and use the Bacon protocol without discussion.
Okay, thank you, doctor.
Also, we have one question regarding the interaction of the pharmaceutical question about the interaction of the TAS with other drugs and with the food. Can you just, Mr. Ala, mention, talk about this issue?
Concerning TAS 102, it is taken with food, whatever it is, heavy meal or standard meal. It should be taken within the 1 hour of the food in the morning and in the evening, because in the fasting state, the availability will be reduced significantly, like 40%. So it should be taken by food. In vitro studies, TAS 102 is not inhibiting the activity of human cytochrome B450. So it would not interfere with most of the medications. Caution, there is a caution is required when using medicational products that are human thymidine kinase substrate, like the antiviral zidovudine. So when using antiviral medication products that have a thymidine kinase substrate, you should monitor the possibility decrease of the efficacy of the antiviral. And this is the main caution with the interaction. Other than that, it is safe medication to be considered.
Thank you. I think any more questions? Or I cannot.
The conversation.
Mm-hmm.
I want to ask you, Doctor, what's your current practice beyond second line in your center? As I hear that you do not have all the medication like TAS-O 1 or 2.
This is the point that what we are adopting mainly is the Rechallenge and reintroduction strategy. This is the main strategy what we adopt. Looking, and we are, while waiting for the options which we mentioned, that mean for this patient, if the patient did not expose before to anti-EGFR, which is not happens always, unless if the patient referred from another country or other, then we have to expose the patient to anti-EGFR if he is wild type. Otherwise, what we do is Rechallenge or reintroduction of the first line, waiting for the availability and the approval of the other drugs. Now, the good news from you that NABCO almost supplying the TAS, I think will provide a chance for us to use this option, inshallah, as soon.
Okay, thank you, Doctor. I think there is no more questions in the chat room. For that, I can we can stop here. It is Friday in the evening, and it is 10:30 almost. So thank you very much, Dr. Ahmed, for the comprehensive and the comprehensive and informative presentation, updated. So thank you very much, Dr. Ahmed, and inshallah this crisis will be finished to see you physically in Najran in King Khalid Hospital.
Sure. Thank you very much. Thank you for you. Thank you for Ahmed thank you for all the attendees, and thank you for Sirfiye for this educational activities. And see you inshallah soon, bidnillah.
Inshallah. Thank you. Thank you, our audience. Assalamu wa rahmatullah.
Assalamu. هلا، السلام عليكم. كيف الحال؟ الله يحفظك، الله يعطيك العافية. ما شاء الله محاضراتك ممتازة جدا، الله يحفظك يا رب. كثير يرسلوا رسائل يقول لي ما عرفنا ندخل، مش عارف ايش اللي فيه صعوبة في بعض، ما شكله. اه ايوه، شفت انت الحضور، انا مش مبين عندي كان الحضور. ايوه انا شايف، ما لاحظت يعني، انا ركزت شوي في المحاضرة اكثر من الحضور. ايوه ايوه ايوه، يعني قدر الله قدر الله. ايوه اي اي، بعضهم الويكند اي 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 اي، ان شاء الله. الله يحفظك، الله يجزاك الخير. شكرا شكرا شكرا، جزاك الله خير. السلام عليكم. مع السلامه. شكرا.